What we will be discussing today is the role of plasmapheresis for patients with acute and acute on chronic liver failure. Acute liver failure and acute on chronic liver failure, of course, there are two different animals. But the main culprit is severe hepatic dysfunction associated with multiple organ failures, and it is associated as well with significant morbidity and mortality. Why does this happen? Why do we have all of these organs actually following in a domino effect after the liver is failing? We don't know exactly, but it has been speculated that this has to deal with excessive systemic inflammation. It is regulated immune activation, and this is triggered by both microbial and non-microbial factors, and of course, by the primary insult to the liver. Now, besides treating the underlying disease, that can be viral, can be alcohol-associated, can be autoimmune, we need to provide supportive therapy and provide actually the time for patients with acute liver failure to have a sort of regeneration, or for patients with acute on chronic, just bypass the triggering factor. And if this is not feasible, start looking at the ultimate treatment, which is liver transplantation. But as you know, grafts are not readily available. We cannot have it whenever we need it. So we need to buy time. Another component is that the availability of organs as well is limited. And finally, liver transplant is not something that it is available worldwide. There are some countries that liver transplantation is very, very limited. So we need to do something in order to stabilize these patients as much as we can. Now, try to look at the multiple organ failure in patients with acute liver failure. We have the release of damage-associated molecular patterns from injured hepatocytes, and also we have microbial pathogen-associated molecular patterns released in the presence of superimposed infection or sometimes bacterial translocation. As we know, patients with liver failure might develop significant portal hypertension edema that influences the integrity of the gut. And when the tight junctions are not that tight, we have patterns escaping from the gut, funneled through the portal vein into the liver, and this initiates an inflammatory cascade. In addition, the immune cells that are activated by the DAMPs and PAMs produce pro-inflammatory cytokines, such as interleukin-6, interleukin-1b, interleukin-8, TNF-alpha. And actually, this mediates a systemic inflammation and perpetuates the hepatocyte injury and necrosis. When we looked actually at the levels of these inflammatory cytokines, you see that the TNF-alpha and interleukin-6, for example, have shown to be significantly higher in patients with acute liver failure compared with other conditions. Of course, as we discussed, all of these things induce the immune system in such a way that we have an increase of white blood cell count and C-reactive proteins, among other inflammatory molecules. And of course, there is a correlation between the cytokine levels and the number of organ failures in patients with liver failure. So let's take a look at this illustration. As we discussed earlier, we have the acute injury that is affecting the hepatocytes and induced necrosis with the release of inflammatory cytokines and also the DAMPs, in addition to the activation of the immune system, as you can see, and the leaky gut syndrome with all of these mediators inducing increased levels of inflammatory cytokines, perpetuating the inflammation, hepatocyte death, and of course, multiple organ dysfunction as a part of the systemic inflammatory reaction as well, and organ failure. And sometimes actually people are asking, okay, there was an infection, that we treated the infection, why this situation is not bouncing back? Why this liver is not bouncing back? This is why, because the cascade has already started. And once you have the production of the inflammatory cytokines, the SIRS is actually perpetuating this situation. And this is what's happening in the microenvironment. As you can see, all the inflammatory molecules affect the hepatocytes. And of course, this induces portal hypertension and microcirculatory dysfunction. Now, treatments for this situation is relatively limited. And of course, besides providing the standard medical therapy and try to eliminate the eliciting factor, we need to start thinking if we need to advance these patients towards the next step, which is liver transplant evaluation, or if there is any chance to preserve the liver function and try to bounce back when liver transplant is contraindicated or unavailable. Because besides the fact that we have limited resources and supply and demand is something that is always under discussion regarding graft availability, there are some situations that we are not able actually to advance the patient for liver transplant due to social issues and other issues as well. So plasmapheresis is something that has been actually entertained in the past. What does this mean? This is the process where the plasma is separated from the blood, either by centrifugation or membrane filtration. It's not something new, it's something that started many, many years ago, actually in Russia in 1913. And later on, plasmapheresis actually was utilized to treat patients with TTP, thrombotic thrombocytopenic purpura, in Los Angeles in 1959. And later on, it was utilized actually at the National Cancer Institute between 1963 and 1968. So plasmapheresis or plasma exchange is the technique of discarding the plasma totally and substituting it with replacement fluid. It involves the removal of the liquid portion in order to remove all the inflammatory molecules, as we discussed earlier, and also albumin. And we will be discussing the importance of albumin later on, as albumin has multiple actually functions. And one of them is transporting molecules from one area to another, including inflammatory cytokines. It's like a sponge. And of course, therapeutic apheresis of plasma is performed in a way that all of these toxic elements will be removed. What do we need to do? First of all, we need to have access. We need to calculate the total plasma volume, and after that, decide what type of plasmapheresis we would like to do. Is this high volume, low volume? Later on, proceed with sessions. How many sessions? We need to make sure we have anticoagulation, or what type of fluid we would like actually to substitute with, and proceed. Another component is we are removing antibodies, and sometimes we need to replenish actually the antibodies we're removing with, especially IgG, with IV IgG. We need to have a very good workup before the procedure with biochemistry, complete blood count, coagulation. We need to make sure that we have checked for infections and also blood type and all of these things. And of course, during plasmapheresis, we need to monitor the biochemistry, the complete blood count, coagulation, and specific tests. How do we calculate the total blood volume? This is the Nadler's formula. I will not actually spend much time with this, but it's different for a man, different for a woman. And after we calculate the total blood volume, then we are moving forward and we have the percentage calculated of the plasma we would like to remove. As we discussed, plasma exchange is when plasmapheresis is followed by replacement with fresh frozen plasma infusion. Now, the practice, as we discussed, started years ago, back in the 60s, for patients that were in hepatic coma. And later on, they started looking at some additional indications in order to administer this kind of procedure and stabilize the patients. The first randomized controlled trial is something we will be discussing later. It was in patients with acute liver failure by Dr. Larsen in 2016, and this was actually published in Journal of Hepatology. This is one of the first publications I was able to identify plasmapheresis in hepatic coma. As you can see, this was in the Lancet in 1969. They utilized this in 4 cases. You see that the 4 patients were women, 54, 21, 17, 22 years old. Hepatitis A infection and hepatitis B was calculated. The total plasma exchange was about 5 liters over 3 days in the first case, 6 liters and 8 liters over 3 days in the third, and 17 liters over 6 days in the fourth. So some of them were stabilized, some others actually were not able to stabilize and unfortunately succumbed. Another publication was around the same time. This was in January 1968, treatment of hepatic coma and cirrhosis by plasmapheresis and plasma infusion, which is the plasma exchange. 3 patients actually were underwent the procedure, and in each case, they noted that coma was cleared after this kind of therapy. So this is the main culprit, because what we try to do is try to remove large compounds from the blood, including albumin-bound and water-soluble toxins, and replace them with fresh frozen plasma and or albumin. And the toxins we try to remove is inflammatory cytokines, endotoxins. You know that bilirubin is toxic in high levels, bile acids, ammonia, and aromatic amino acids. So try to put everything together. You see the inflammatory molecules, the way we discussed earlier, including ammonia, bile acids, bilirubin. You see molecules due to the bacterial translocation with the dumps and bumps in the inflammatory cytokines. And here is where therapeutic plasma exchange is coming in order to remove all of these substances and decrease the levels, and of course, try to break the cascade of the inflammatory or the inflammation that influences actually the other organs, inducing organ failure, which is acute kidney injury, cardiac dysfunction, and of course, cerebral edema. This is the publication I discussed with you earlier by Dr. Larsen in Journal of Hepatology in 2016, high volume plasma exchange in patients with acute liver failure. This was actually an open randomized controlled trial. High plasma is defined as exchange of 8 to 12 or up to 15% of the ideal body weight with fresh frozen plasma administered. This was a prospective randomized controlled multi-center trial. 182 patients were enrolled, 90 were in the standard medical therapy, and 92 in standard medical therapy plus high volume plasmapheresis. Then primary point was transplant-free survival during hospital stay. Secondary point was survival after liver transplantation, with or without the procedure. And it was actually a proof of principle, evaluating the effect of HVP on immune cell function as well. So this is the stratification of the patients that was almost identical. You see, it was mainly women, young age, 45 years old, and the etiology was acetaminophen or paracetamol, acute viral hepatitis, toxic hepatitis, Budd-Chiari, and some cryptogenic. And all patients receive at least one treatment session with HVP. And all the 182 patients were included in the intention to treat analysis. The mean number of plasma exchange per patient was 2.4, and the mean plasma volume exchanged during the first session was 9 liters approximately during the sessions. So the mean length of stay was almost 22 days in the HVP group compared to 41 in the standard medical therapy. 46, almost 50% of the patients in HVP and 44 in the control group were listed for transplantation. 26% of the patients in the HVP group underwent transplantation as compared to 35% in patients with the control group. At the mean time for transplantation following listing was 4.6 days in the HVP versus 3.7. So the survival to hospital discharge was 58.7% for patients treated with the plasma exchange versus 47% for the control group. As you can see, the hazard ratio for the high volume HVP versus standard medical therapy was 0.56. And this was statistically significant. So there is some merit for this procedure. And you can see actually the log rank over here and the difference. Actually, the survival starts separating very quickly, actually, by the first week, by day 7, and remains actually up to 90 days. And if we try to break down in different actually stratifications, of course, patients who got the liver transplant had actually the best survival, but you can see patients with plasmapheresis as well did much better in comparison with the other ones. And the survival of those patients who actually had poor prognostic criteria but were not listed for transplantation due to contraindication was significantly higher in those who received plasma exchange plus standard medical therapy. Now, there was non-significant trend in those listed for transplantations, but not over a graft, of course, due to the development of contraindications and to have improved outcome in the group of patients treated with high volume plasma compared to standard medical therapy. Now, looking at the clinical variables, the majority of them actually significantly improved, and this is anticipated because when you do the plasmapheresis, actually, and you administer first frozen plasma, what you check is the plasma of the donor. There was significantly fewer patients in the high volume plasma who required renal replacement therapy, and compared to the control group, which was 47 versus 68%. And you know, this is very important. Once patients develop renal failure, kidney failure, and they are advancing to multisystemic organ failure, they're not doing very well. Now, the mean arterial pressure increased significantly in the plasma exchange group. And of course, other physiological parameters were unchanged. The ICP was measured in 16 patients in the plasma exchange group and 16 in the control group during the 7 days of the study. There was no differences in ICP. People speculate that when we do plasma exchange, sometimes this can induce intracranial hypertension due to volume, but this was not the case over here. Looking at the serous and SOFA scores, decreased in the plasmapheresis group from day 2 when compared to the baseline, and this is actually very important. Now, adverse events, arrhythmia, pancreatitis, worsening gas exchange, ARDS, TRALI, infections, bleeding were monitored, but not statistically significant was identified between the two groups. And as we discussed in the beginning, one of the areas that needed to be investigated was the level of the inflammatory cytokines. I'm keep on bringing this back and back and back because this is the culprit. As we discussed earlier, even if the illicit factor is treated like an infection or bleeding, the cascade keeps on going. And as you can see, actually, I know this is a pretty busy slide, but what I would like to discuss with you is that if you look at the left side of the graphs, there is a significant decrease of the inflammatory cytokines for patients who underwent this kind of procedure. So this was the first time that patients with acute liver failure demonstrated an improved transplant-free survival by using this procedure. And this provided the rationale for further comparative studies, testing high volume plasma exchange for this kind of patients or patients with ACLF. So, and of course, you know, the fact that there was a decreased need for transplant, this was really very appealing. There was an editorial, actually, by Dean Corvallis and Todd Stravich that was published along this paper. And what they mention is that there is a widespread availability of administering this type of procedure without specialized equipment or culture hepatocytes. And this is really very important, as plasmapheresis or plasma exchange actually is something that is worldwide utilized so far. And of course, I was a part of the ELAD trial that we had to find cartridges with hepatocytes and other elements that are not available actually around the world. And this made this situation very difficult. But you know, this is something that it is available worldwide. And of course, given the fact that rapidly early upregulation of sears and the high potential for recovery is under consideration. Now, this is a very recent trial that was published actually in Clinical Gastroenterology and Hepatology by Professor Sarin. Standard volume plasma exchange improves outcomes in patients with acute liver failure. This was a randomized controlled trial. It's an open label randomized controlled trial. 40 consecutive patients with ALF were randomized 1-to-1. They will receive standard medical therapy or SMT and plasma exchange. This was performed by using centrifugal apheresis until desired response was achieved. Cerebral edema was assessed. Always, we need to keep an eye on this. And the results were analyzed in an ITT fashion. The primary outcome was 3 weeks transplant-free survival. And of course, the level of inflammatory molecules such as cytokines, DAMPs, and endotoxins were analyzed at baseline at day 5. You see that these are young patients. 60% were men. The age was 31.5. The majority of these patients suffered from viral infection. 70% actually had evidence of sears. And at day 5, you see that the plasma exchange compared to standard medical therapy alone resulted in higher lactate clearance, improvement of sears, 84 versus 26%, which is a pretty appealing number, reduction in the ammonia levels, and the SOFA scores as well. There were no treatment-related deaths, which is very important, and this type of procedure was associated with a higher 21-day transplant-free survival, 75% versus 45%, and a significant decrease in the levels of the inflammatory cytokines. They discussed that in ALF patients with cerebral edema, this procedure is safe and effective and improves survival by reduction in the cytokines storm and ammonia. Of course, something that I would like to bring for discussion, we know that when the ammonia level is increasing more than 150 to 200 for patients with acute liver failure, this can induce significant cerebral edema. By decreasing the ammonia level, of course, we decrease the likelihood for these patients to not only develop intracerebral edema, intracranial hypertension, but also decrease the chance of herniation. So now, patients with acute liver failure, this is the stratification of the trial. They looked at 126 patients. They include actually even very young people, and 20 were enrolled in the plasma exchange, 20 in the standard medical therapy, and they followed these patients. You see that 4 of them in the plasma exchange group succumbed versus 11 in the standard medical therapy. And this is the curve, as you can see, which is statistically significant. And there is a 21-day transplant-free survival benefit when we use this procedure. And these are the level of inflammatory cytokines. As you can see now, it's the blue one is the one that is tested after the plasma exchange, and there is a significant decline of the inflammatory molecules. So there was another publication, plasma exchange in patients with acute and acute on chronic liver failure. This was a systematic review that was published in the World Journal of Gastroenterology a couple of years ago. So they look at the patients with ALF, ACLF, those who underwent plasma exchange with or without alternative liver support systems, and they try to compare and look at the outcomes. They look at 324 citations identified by electronic search that was performed up to March 2019. And 262 records were screened. 51 articles was assessed for eligibility, and 44 studies were included in the systematic review. ALF 29, ACLF only 9, and 6, both of them. Of the 44 studies, 2 were randomized control, 14 were cohort studies, 12 case series, and 16 case reports. And what they found out, there was, this is the forest plot for 30 and 90-day mortality in acute and chronic liver patients undergoing plasma exchange interventions versus standard medical therapy. And as you can see, they identified that the majority of them actually had a positive outcome, and the intervention actually resulted in increased survival of these patients. This is what we discussed. Then, of course, they look at the biochemical variables, and they identified improvement pre and post the procedure, though the biochemical improvement did not directly relate to the mortality outcome. As we discussed earlier, we know that when you do plasma exchange and you provide fresh frozen plasma, you are checking the donor for quite some time. They mentioned that there is a heterogeneity, of course, in the amount of plasma exchange in patients that got different calculations, high versus standard therapy. But 2 studies that they use plasma exchange at least 15%, which is the high volume plasma, and with the removal of 1 to 2 liters per hour, they were looked at, and some other studies had the same outcome. The majority of the studies use approximately 2 to 4 liters of fresh frozen plasma at each plasma exchange. And the majority of them used FFP, and a few used albumin. Now, only a few studies had very strict consecutive daily or every other day 3-day therapy plasma exchange regimen. You see that this can happen consecutive or every other day. So there is, long story short, what I'm trying to say is that this has been utilized, but this has been utilized not in constant or the same fashion for everybody. So people were introducing different ideas, different calculations, and different kinds of scheduling to perform the plasma exchange. So some other as well utilize, besides plasma exchange, artificial devices like CVVHD and hemoperfusion. So there is a significant heterogeneity. Same thing over here. You can see also some other studies included pediatric patients, some other don't, some other used a mixed bag between ACLF and ALF. There was a big variability for these patients. So 3-day therapy versus intermittent was looked at this. All the studies actually didn't have the same, as we discussed earlier, scheduling, and heterogeneity is remarkable. So some of them included patients with chronic liver injury due to hepatitis C and alcohol, some with hepatitis B and alcohol, some with autoimmune. And for these patients, the mortality was really pretty high. Of course, you know, when you try to incorporate different kinds of the world, different areas of the world, like Asia versus Europe and United States, you have a different epidemiology. As we know, in Asia, hepatitis B is more endemic than other areas. But what is coming down the pike? The best way to predict the future is to invent it. So, and this is the Apache trial, which is the short-term survival of subjects with acute and chronic liver failure after plasma exchange with albumin, actually, administration. So this is an ongoing trial that was based on the observation of Professor Larson, the paper we discussed earlier published in Hepatology. This is a phase 3 multi-center randomized control parallel group open label study to evaluate the effects of plasma exchange using human serum albumin 5% in acute and chronic liver failure. The study involves approximately 40 study centers in the United States, Canada, Europe, and with expertise in the management of these patients. Of course, we know patients with ACLF are at high risk of hospital mortality. The study consists of screening period during which subjects are randomized 1-to-1 to receive SMT and plasma exchange with albumin infusion or standard medical therapy only, that this will serve as the control group. And these patients will be followed. The treatment period will range between 7 and 17 days, depending on the ACLF evolution. And of course, a minimum of 7 days will be needed for these patients in order to stay in the trial. The follow-up period for subjects in both groups is 90 days. I am the PI, the national PI for the United States at this point, and I'm really excited to see this trial keep on going. And approximately 380 subjects with ACLF 1B to 3A, up to 3A, will be included in this study. In case of hepatic encephalopathy, and of course, the patients will need to sign informed consent. If they suffer from hepatic encephalopathy, then a relative or the legally authorized representative is consenting these patients. The randomization of the subjects will be stratified according to the region, European Union or North America, and of course, according to the ACLF grades, ACLF 1B to ACLF 3A. And these patients, as we discussed, will be randomized in 1-to-1 ratio into 2 treatment groups. The albumin will be administered at 5% as the main replacement fluid. IV and fresh frozen plasma will be given after each plasma exchange to prevent coagulopathy. So there will be 2 sessions consecutively, and after that, every other day, and then up to the maximum of 17 days response. And IVIG will be administered in order to prevent hypogammaglobulinemia and infection. In the standard medical group, the treatment period will be 7 days for subjects and will be prolonged depending on the subject's evolution of ACLF up to 17 days. And of course, both of the groups will be followed for 90 days after randomization. Of course, there is a DSMB, Data Safety Monitoring Board, that is coming together, reviewing all of the adverse events. Primary outcomes is time to death through day 90. And secondary outcomes is time to transplant or death through day 90, time to death through day 28. Now, couple of things regarding albumin. Albumin actually is the most abundant plasma protein in the body, modulates plasma oncotic pressure, and this is what we know actually from medical school. But something that people tend to forget is that albumin has multiple actually functions. One of them is reversibly bind to an extremely wide range of ligands and transporting. This is the best cargo ship that we have in our blood. Besides the oncotic pressure and the transportation, there is some anticoagulant, antithrombotic effects. There are some antioxidant effects, free radical scavenger. The albumin actually is very important for the capillary integrity, and of course corrects the immune dysfunctions by binding endotoxins. So it's like a chameleon. As you can see, there are multiple functions. Now, albumin, this is the human serum albumin, that when there are some inflammatory molecules, reversibly actually is changed to HNA1. But if actually we keep on having inflammatory molecules, this is actually getting to the HN2A component, which is the deleterious effect, as this one is like a sponge, getting all the inflammatory molecules around and perpetuates the multisystemic organ dysfunction. And in the end of the day, this is like a grenade. This is very important for us to know. That's why when we utilize plasma exchange, we need to remove the albumin and provide fresh albumin in order to ameliorate the inflammatory cascade. And this is how albumin is in healthy individuals with all of the binding antioxidant activities, endothelial stabilization, and so on. And this is what's happening in patients with decompensated cirrhosis, though there is a structural damage, reversible and irreversible oxidation, and impaired dysfunction, actually, impaired function, reduced antioxidant activity, binding detoxification, and other things. So now plasmapheresis and plasma exchange actually is something that the European guidelines recommend for patients with acute liver failure. Plasma exchange and randomized control trials has been shown to improve the transplant-free survival and may be of greater benefit in patients who are treated early and who will not ultimately undergo. In other words, what the European guidelines discuss with us is think about plasma exchange and don't be late. If it is to start it as quickly as possible for these patients. Having said that, I would like to thank you very much for your attention. I think this is something that perhaps we forget to implement for our patients, in particular for patients that are not transplant candidates. And again, I would like to express my appreciation to Dr. Satapathy in the intensives group for giving me the opportunity